All right, welcome everyone. Today, we're going to tackle a topic that is just absolutely fundamental for any practicing clinician, and it's a huge must-know if you're prepping for your specialty exams. We're talking about the risk factors for venous thromboembolism, or VTE. And just so you know where this great information is coming from, all the content for today's explainer is credited to the work of Dr. Mohammed Al-Nagi Mohammed. The really comprehensive list we're about to go through is also partly based on the 2010 SIGN VTE guidelines. So here's how we're going to break this down. We've got four main sections. First up, we'll look at the general predisposing factors. Then we'll dive into the medical conditions that are associated with VTE. After that, we'll talk about medication-related risks. And we'll wrap up with a really important clinical point about the cases that just don't have an easy explanation. Okay, let's jump right into section 1. We're starting with the big ones, the common patient-related risks that you're going to see pretty much every day in your clinical practice.
So a lot of these probably aren't a surprise to you, right? Advancing age, obesity, a family history of VTE. We know these. But as always, the devil is in the details. Take a look at pregnancy. The risk is there, but it's especially high in the puerperium, that postpartum period. That's a key clinical pearl. And for all of you in critical care or anesthesia, this last one is huge. The location of a central line really matters. A femoral line carries a much higher risk than a subclavian one. Why? Well, it's all about venous stasis and just how close it is to the deep veins of the leg. It basically creates the perfect storm for clot to form.
All right, moving on to our next section. Here, we're going to look at how certain underlying diseases can actually create a prothrombotic or clot-forming state in a patient. Okay, this list right here, this is classic high-yield stuff for your exams. Malignancy is a huge driver of VTE. Same goes for those inherited thrombophilias, like activated protein C resistance or deficiencies in protein C and S. But you've also got to remember things like heart failure and autoimmune disorders, like antiphospholipid syndrome. They're all major players here, because at the end of the day, they all lead to the same problem. They push the body into a hypercoagulable state. And this next list just shows you the sheer range of conditions that can set a patient up for VTE. I mean, look at this. You've got hematological issues like polycythemia and sickle cell, all the way to something like nephrotic syndrome, where the body is literally losing its natural anticoagulant proteins. It really drives home the point that VTE isn't just one specialty's problem. It's a systemic concern that touches almost every part of medicine. Okay, next up is a really critical category, especially when you're taking a patient's history. We're talking about medication-induced VTE. You know, these are the iatrogenic risks, the ones that we as clinicians have a direct hand in.
Pay close attention to this one. It's a classic exam question, but it's also a super important clinical detail. When it comes to combined oral contraceptives, the specific formulation really matters. The third-generation pills, the ones with newer progestins like desogestrel, they carry a higher thrombotic risk than the older second-generation ones. That's a nuance that can absolutely change your prescribing decisions and has a real impact on patient safety.
And you know what? We see a really similar pattern with hormone replacement therapy. The risk profile totally changes depending on what's in the medication. The combined PrEPs, the ones with both estrogen and a progestogen, they have a higher VTE risk than therapy with just estrogen alone. Again, this distinction is absolutely crucial when you're counseling patients and figuring out the safest management plan. And we can't forget these two big ones, raloxifene and tamoxifen. They're both what we call SERMs, selective estrogen receptor modulators, and you'll see them a lot in the context of breast cancer. And yes, they are very well known for increasing the risk of VTE. A big part of how they do this is by messing with that delicate balance of pro- and anti-clotting factors in the blood. Okay, now for something that's been highlighted more recently. We're now seeing studies that show certain antipsychotics are an independent risk factor for VTE, with a lot of the focus being on olanzapine. This is a really key piece of emerging information, not just for our colleagues in psychiatry, but for anyone in general medicine. We need to be aware of this, even while the exact why is still being figured out. All right, so we've gone through all the major identifiable risk factors, but now we get to what might be the most crucial part of this whole discussion. We're going to talk about the cases that just don't fit the mold. 40%, just let that number sink in for a second. In a staggering 40% of patients who are diagnosed with a pulmonary embolism, we can't find any of the major risk factors we just spent all this time reviewing. That is the reality of clinical practice. And what it means is that we absolutely cannot just rely on ticking boxes on a risk factor checklist. And that brings us to our final and most important takeaway, That statistic forces us to ask the question, when a patient shows up and they don't tick any of the classic boxes, what do you do then? It hammers home the point that beyond any checklist, our most powerful diagnostic tool is and always will be a high index of clinical suspicion. So the next time you have a patient with symptoms you can't quite explain, remember that 40% and make sure you keep VTE on your differential diagnosis.